Yes, so I spoke on the role of the geriatric assessment in older adults with head and neck cancer. Mainly I focused on reviewing the current literature available of studies that have incorporated geriatric assessment and outcomes for older adults with head and neck cancer. I think we're starting to get more information about the potential role and benefits of utilizing geriatric assessment tools in evaluating and potentially risk stratifying patients who are older, particularly with locally advanced disease, for more intensive treatments such as chemoradiation with curative intent. I think the theme for the whole discussion this morning was we all need better selection of patients for more aggressive treatments such as concurrent chemoradiation, because we can still cure patients with that, but of course there's the cost of the toxicities, both short and late term. Some of this, my co-discussants emphasized, some of the late term toxicities that we're probably not as focused on, such as stroke risk, particularly in the older survivors. That goes up significantly at 10 years compared to younger patients. I think from the geriatric assessment studies I reviewed, particularly the Belgian study, that we can use tools like a G8 that is more conducive time-wise for evaluating older adults, that patients who are deemed fit or unfit based on that do have remarkably different trajectories in terms of their quality-adjusted survival, as well as patient-reported outcomes. I think they had a fair number of patients. I think it was over 100. Some of the other studies that we reviewed were only in the 30 to 40 range, but I'm pretty confident that study had a much larger sample size. And those patients were predominantly up to 70% or so were getting definitive chemoradiation or radiation, as opposed to many patients getting surgery and then additional treatment. So it was a little more homogeneous in terms of treatment type. So I think in terms of the patients we're typically addressing with some of the long-term quality of life issues from the medical oncology side, we're going to be more involved with chemoradiation patients. So it's definitely a little a more germane study to look at, to gain some insights about the potential use of G8 and comprehensive GA in that population. I don't think we have a consensus yet. As opposed to patients with more advanced stage disease, where many of these tools have been used to predict chemotherapy toxicity and survival in general, head and neck patients were generally not included in any of those earlier studies. I think it is helpful, based on a review that we discussed, that utilizing a GA to be more mindful of patients who may have poorer, at least self-reported functional outcome issues, or potentially worse survival overall, whether we should look at either modifying the treatment recommendations, but I think the group as a whole didn't recommend any dose adjustments. So I think it'll boil down to, is it single modality versus combined modality treatment based on the geriatric assessment results, or the G8 score at baseline, as well as tailoring that to the frequency of visits and the amount of supportive care that will be necessary to support that more vulnerable patient through whatever treatment intensity is deemed most appropriate for a given patient. But I don't think we're at the point yet of being able to use the tools yet to decide what type of treatment necessarily, or dosage, or because I think a lot of the landscape, as we all allude to in our talks, especially with immunotherapy on the horizon, and that being incorporated both in the early stage as well as the recurrent metastatic setting, the paradigm shifting in general for all patients. But I think for our older patients who might be more vulnerable functionally or because of comorbidity, at least it's so far useful to use these tools to help guide general treatment decisions in terms of overall intensity and how to better approach supportive care during and after treatment. Other than we're definitely eagerly awaiting some of the geriatric assessment embedded trials being done right now in France, adapting chemotherapy choice for the patients with recurrent and metastatic setting, as well as the general overarching trial looking at geriatric assessment and functional status, disability, and nutrition and similar outcomes in a much larger cohort of older adults with head and neck cancer to help fill in some of these knowledge gaps.